Hi, this is Dr. Gary Schwartz, and I am going to give a short presentation on macular degeneration targeted for primary care providers. Age-related macular degeneration is a leading cause of blindness in the United States and in the world. And its prevalence increases with age. So it affects very few people under the age of 60 and affects a significant proportion of the population above age 80 and even more so above age 90. Its major risk factors are family history and age, and then also cigarette smoking. So let's do a quick review of the anatomy here. Why the term macular degeneration and not like retinal degeneration or foveal degeneration? So here is the retina. Retina is kind of a generic term for all this tissue in the back of the eye. So retina is like a tissue diagnosis. The macula is more of a geographic diagnosis. It's this area here between the main superior blood vessels and the main inferior blood vessels. This is a part of your eye that's like when you're looking straight ahead, this is where most of the image will fall. And then this very small area in the middle is the fovea. That's this part here when you look at it in cross section. So fovea is an anatomic definition. Retina is an anatomic definition, and macula is more of a geographic definition. And the terminology is such that we just choose the term macular degeneration because the macula is the area that best describes where this disease involves. So macular degeneration is thought of as a progression, where one end of the progression spectrum is the normal eye. The early stages are what's called drusen, and drusen are these yellow collections at the base of the retina or just under the retina, and it's felt to be just the retina not being able to manage its waste products effectively. So drusen, as you'll see coming up, are these little yellow dots in the back of the eye. Then the next stage after drusen is dry macular degeneration, where now you have drusen, you've got some signs of destruction, you've got a little bit of vision loss. If this continues to progress, the late stages is atrophy, where you have a loss of tissue. And then dry macular degeneration can then develop into wet macular degeneration, which means there's fluid or blood involved, and the late stages of that is scar tissue. So this is a progression where it starts normal, then you get drusen, then you can get dry, and then you can get wet. So dry and wet are not two different branches of the same tree. Wet is a sequelae of dry that some people will go on to get. Many people don't, but many people do. So let's look at pictures of all of these. So this is the normal retina, and like we said, this part here is the macula, and this is the part that where most of your looking straight ahead vision falls. This little bit here is the fovea, and then the whole thing is your retina. And then you see the optic nerve here, and then the retinal vessels, the bigger, darker ones are the veins, and the smaller, lighter colored, redder ones are the arteries. So that's normal. So these yellow dots are drusen, and drusen can be little or they can be big. They can be clearly defined, in which case we call them hard drusen. They can be kind of poorly defined, like these are. They're a little fuzzy. Those are called soft drusen. And the reason drusen can look fuzzy is they're at the base of the retina. So you're looking through a fair amount of retinal tissue to see them. And you can tell because of the way these blood vessels go over the drusen. Right? So the blood vessel, you can see the drusen you lose. So that tells us that the blood vessel is superficial to the drusen. So now we have dry macular degeneration. And you might say, wait a minute, this looks a lot like drusen. Yeah, it is. There's a lot of drusen there. So why is this picture dry macular degeneration while the previous slide we called drusen? Well, like I said before, they are kind of on a spectrum, so there might be a little bit of give and take there, but the difference could be something like this patient sees 20/30, whereas the patient on the last slide saw 20/20. So it may not be so much a clinical diagnosis, what does the eye look like when I look in? It could be more of a physiologic diagnosis, what does the patient see when they look out? So this is a patient's right eye, because they're looking back at you, remember? This is a patient's left eye, and here we see a hint of this atrophy. So this would be kind of an opening in the retina, and you're looking straight through kind of a window in the retina. This patient might see really well if the fovea is here, because that's pretty normal looking tissue. Or this patient might see really poorly if the fovea is here. So again, the only way to tell how a patient sees is put them in front of the eye chart and see how they see. So this is a closer picture of this late stage, what we call geographic atrophy. And we call it geographic because it's well defined, like the borders of a country. I mean, it's not a very original term, but that's what we use. And what we're looking at here is all these blood vessels here. These are the choroidal blood vessels. So now if we shift our attention to this picture here, this is the surface of the retina, right? This is the fovea. These are all these retinal layers we learned in medical school that nobody really seems to remember. And then underneath you have the choroid. So these blood vessels here are the choroid. Normally when we look at the choroidal vessels, they're hard to make out because we have to look through all this stuff to see it. And that's what's going on here. You can make out choroidal vessels, but they're not overly clear. But this patient has atrophy, which means this whole part is just gone. There's nothing here anymore. So you're looking at the choroidal vessels laid bare. So that's what this is. These vessels are always there. They're just usually harder to see. So wet macular degeneration is everything that we just talked about, but now with some sort of fluid. In this case, we can see the blood pretty clearly. There's also probably some clear fluid that's associated with it as well. And the blood is deep. If you can see these vessels, maybe I'm imagining a little bit, but the vessels actually course along the surface of it. So the blood is under the retina, and it kind of will end up kind of in the retina at some point, but usually the blood starts out underneath the retina. It's a subretinal neovascularization. And then if wet macular degeneration here's a nice picture of how deep the blood is. So this dark stuff is actually red blood, but it just looks dark because it's under all these pigmented layers. And you can see the superficial retinal vessels really coursing across the surface of the retina here. If this cannot be treated, this may over time turn into scar tissue. This is very different than the geographic atrophy that we looked at before. Geographic atrophy, we could see the choroidal vessels very clearly through an open window. Here it's the opposite. You can't see the choroidal vasculature because this is a white scar now. And again, you see the retinal vessels course over this white scar. So the white scar is within and below the retina. And this is conducive to very poor vision. So again, go over this again. The progression is normal. We start out normal. We develop drusen, yellow waste product concretions at the base of the retina. If these are allowed to coalesce or get worse or be associated with some damage, now we call it macular degeneration, which can get bad. It can lead to an atrophic geographic atrophy area. And then if there's abnormal blood vessels or bleeding associated with it, then it's called wet macular degeneration, which can lead to scar. So progression, normal to drusen to dry macular degeneration to wet macular degeneration. So how do we treat it? So again, I said the major risk factors are age, which you can't do anything about, family history, you can't do anything about, smoking. So smoking cessation is something that can be used to help patients with macular degeneration, to slow down the progression of it. So if patients are looking for one more reason to quit smoking, here's another reason to quit smoking. And then the last thing we have is we have these AREDS2 vitamins. The last thing we have for dry macular degeneration. And AREDS2, here's 4 brands. Here's one put out by, was it SBH? One of them put out by Cystane, one of them put out by Bausch & Lomb, and another one put out by Bausch & Lomb. And the key with all of these is they're all AREDS2. They're all AREDS2 formulas of vitamins. And what is AREDS2? AREDS2 is based on a study, the Age-Related Eye Disease Study version 2. And anything that says AREDS2 on it has this combination of things. So the Cystane eye caps and the Bausch & Lomb Preservision, if they're both AREDS2, they both have the same exact collection of stuff in it. Some of them have 2 pills a day, some of them have 3 pills a day. Some are 4 pills a day, but that if you add it all up, it's all the same stuff. And taking this combination of vitamins, basically, and minerals every day decreases the likelihood that a patient will lose vision from macular degeneration, or it will increase the likelihood that they will do better on this than off it. So nothing can reverse vision loss. What we're trying to do is prevent worsening for dry macular degeneration. For wet macular degeneration, the idea is to reverse vision loss. So in wet macular degeneration, the problem is related to the fact that they have abnormal blood vessels breaking through these brittle layers in the back surface of the retina. So once the blood vessels are there, we try to get them to resorb, and the best way to do that is with VEGF inhibitors, vascular endothelial growth factor inhibitors. And you folks are familiar with these with other types of diseases. For the eye, the medicine is injected directly into the vitreous cavity, so these are called intravitreal injections. Here is a picture, a buckshot photograph, so if you don't want to see a needle in someone's eye, shut your eyes for a couple of seconds. So here is how we do it in clinic. This is done in the clinic. It takes a very short period of time, basically like giving someone a shot in the arm, although we prep it a little bit more carefully. And this works very well to dry up blood vessels related to wet macular degeneration. Okay, we're on to the next slide for those who close your eyes. So takeaways. Macular degeneration is a leading cause of blindness in the United States and in the world. Its incidence increases with age. The biggest avoidable risk factor is smoking, but most of the risk factors aren't avoidable, age and family history. If you have dry age-related macular degeneration, taking AREDS 2 vitamins is the best thing you can do, aside from quitting smoking, to try to slow the progression of it, either worsening dry or developing wet macular degeneration. If you have wet macular degeneration, you can have injections of anti-VEGF, and what that does is it causes the blood vessels to get resorbed, dry up, go away, whatever you want to call it, and it essentially turns wet macular degeneration back to dry. It gets the blood vessels to go away. But it only lasts like a few months. So these have to be repeated, and usually repeated on a schedule. Usually these are being repeated every 6 weeks, 8 weeks, something like that. So when a patient starts getting VEGF inhibitor injections, it's not uncommon for them to keep getting them every few months for years. And even one piece of this is, as bad as their vision gets from it, the problem is macular, which is that central part of the retina. So patients typically do maintain their peripheral vision, which is important because they maintain their ambulatory vision. They can still like avoid chairs and avoid furniture because they still have peripheral vision. So they lose their ability to read, see TV, recognize faces, drive, but they don't tend to lose their ability to walk around. So that is a quick review of macular degeneration. So thanks for your attention. There's my email address. If you have any questions, feel free to drop me a line. And also if you have any recommendations for any other talks. Thanks very much.